Hi, my name is Dr. DJ Heusler. This is going to be the second part of our corneal disease module. Thanks for joining. So for our second module, topics that we're going to cover are going to be ulcers secondary to foreign material, indolent ulcers, anterior stromal ulcers, deep stromal ulcers, descemetocele, melting corneal ulcers, corneal ruptures, conjunctival pedicle grafts, corneal conjunctival transpositions, A-cell grafting, and corneal laceration. So as we talk about ulcers secondary to foreign material, suture material from previous corrections are a common cause of corneal ulcerations. So this case is Gigi, and Gigi is an 8-year-old female mixed breed dog. Gigi had a previous eyelid tumor removed, and the eyelid was sutured with 3/0 PDS. This case had suture material that went full thickness through the eyelid and then was rubbing on the cornea. So suture material was removed from the eyelid, and the ulcer was debrided with a Q-tip. We used triple antibiotic 4 times daily, Terramycin 4 times daily, atropine at the time of the examination, and she returned in 2 weeks with a healed corneal ulcer. This is Fritz. Fritz is an 8-month-old Great Dane. Fritz presented to me 8 weeks post-op repair of a cherry eye surgery. Multiple antibiotics were tried but did not help to heal the ulcer over the past 8 weeks. In this particular case, the eye is telling you exactly where to look. The 3/0 PDS was removed from the third eyelid, which is far too big of a suture to be using in cherry eye surgery. Triple antibiotic was used 4 times daily, and the ulcer was healed within 2 weeks. This is Sam. Sam is a 2-year-old male neutered mixed breed dog. He had an unknown history as he was just rescued. Antibiotics did not seem to improve this patient over a course of a few weeks. As I was looking at Sam, I noticed that as his third eyelid moved, there was a black piece of foreign material that was within his third eyelid. I removed the suture, which was left over from a previous cherry eye surgery, debrided the ulcer with a Q-tip, and triple antibiotic solution was used 4 times daily for 1 week, and at that point he was then healed. Other very common ulcers that we see in dogs, especially middle-aged and older dogs, dogs over the age of 6 years old, are indolent ulcers. Indolent ulcers are superficial, they're painful, they're chronic, and they're typically non-healing. Indolent ulcers appear in all breeds of dogs, but boxers are predisposed. And again, these typically occur in dogs 6 years of age and older. So for some practice tips for everyone in general practice, in order to debride these ulcers, you can apply a drop of proparacaine to the cornea, wait a couple minutes, debride the loose epithelial edges with a Q-tip, use approximately 3 to 5 swabs, and move swabs in multiple directions in order to remove as much epithelium as possible. After the debridement, you can perform a grid keratotomy, typically use a 25 gauge needle, and sedation if necessary, and make superficial crosshatches across the cornea in order to allow the top epithelial layer to adhere to the stroma. In these particular cases, it's helpful to take the patient away from the owner and then use the side of the needle edge to apply crosshatches across the entire surface of the cornea. With these patients, I will usually send the patient home with ofloxacin 4 times a day until recheck. You can also use triple antibiotic ointment or drops if you elect. In a recent paper by Chandler et al. Evaluating tetracycline on refractory corneal ulcers in dogs, it showed that using tetracycline on corneal ulceration helps to speed epithelial migration and movement. So I typically will send my cases home with Terramycin 4 times a day until recheck. You can also use oxypol, or you can get oxytetracycline compounded if Terramycin goes on back order. Oral doxycycline is also acceptable. This, however, has the chance to add systemic side effects such as inappetence and vomiting. I'll give the patient atropine once at the time of the examination in the clinic. We'll send the patient home with pain control of carprofen 2.2 milligrams per kilogram orally twice daily for 14 days, and tramadol 2 to 4 milligrams per kilogram orally 2 to 3 times daily for 14 days. We have the patient wear an e-collar for the full 2 weeks after the procedure, and we use this to prevent the patient from rubbing and scratching at the ulcerated eye. We apply a contact lens, and then we recheck again in 2 weeks. The contact lens provides some healing and some pain control to the cornea during its post-operative time frame. So what other options are available besides a grid keratotomy? More recently, we've been using a diamond burr. A diamond burr is kind of like a battery-driven Dremel which spins and makes little micro striations in the cornea, which allows the top epithelial cell layer to adhere to the stroma. We typically will apply the diamond burr to the entire cornea for about 45 to 60 seconds. The biggest part about using a diamond burr is making sure that your diagnosis is accurate with an indolent ulcer. We never want to use a diamond burr with deep ulcers, stromal ulcers, or infected ulcers. Here are a variety of indolent ulcers in dogs, and as you can see, many of them look very different from each other. The biggest points to consider with indolent ulcers is that the dog is over the age of 6 years old and has not responded appropriately to topical antibiotics. If the dog hasn't healed within 2 to 3 weeks of topical antibiotics and is over the age of 6 years old, an indolent ulcer should be heavily considered. We now move to anterior stromal ulcers. Anterior stromal ulcers penetrate through the corneal epithelium and into the anterior stroma. They typically do have bacterial involvement, and most are medically managed. Many lag ophthalmic dogs develop these ulcers in the center of their cornea because they have an incomplete palpebral response and a decreased corneal sensitivity of their central cornea. It is important to monitor these ulcers as they can progress quickly from an anterior stromal ulcer to a deep corneal stromal ulcer. With these patients, we send them home on ofloxacin 4 times daily. We send them home with a lubricant with hyaluronic acid, which may help prevent ulceration and help them heal more quickly. We provide them with an e-collar, and then we will recheck them again in about 5 to 7 days. It's important to remember not to perform a diamond burr or a grid keratotomy on these patients, as you will make it worse. Deep stromal ulcers penetrate through the corneal epithelium and into the deep corneal stroma. Most have bacterial involvement or calcific degeneration. With deep stromal ulceration, medical management becomes more risky. Many are managed surgically, such as corneal grafting, and we typically start to think about corneal grafting surgery when the ulcer penetrates more than 50% of the stroma. With deep corneal stromal ulcer, these typically involve bacterial involvement or a melting corneal ulcer. Options at this point include intense medical management or referral for surgery. So if we were to medically manage these, we would utilize ofloxacin 4 times a day with the addition of triple antibiotic solution or cefazolin, and I typically will use Terramycin as well 4 times daily. Oral doxycycline twice daily is also very beneficial for these patients. We have them wear an e-collar until they're rechecked again, and we typically will see them for a recheck examination in 5 to 7 days. Surgical therapies to consider include conjunctival pedicle grafting. This provides a stronger corneal structure. It's a better watertight seal. There's minimal inflammation that is involved when you place a conjunctival pedicle graft. One drawback of a conjunctival pedicle graft, though, is depending on the size of the graft, it can add a blind spot to the patient, obstructing vision. A-cell grafting is another corneal graft that we utilize in veterinary ophthalmology. It has a weaker corneal structure as compared to a conjunctival pedicle graft. It is highly inflammatory to the cornea and generates quite a vascular response. However, when it is completely healed, it leaves a minimal corneal scar, so a very small, if any, blind spot. A Descemetocele penetrates through the epithelium and the stroma to reach Descemet's membrane. Most of patients with Descemetoceles have bacterial involvement or severe calcific degeneration. So in this first picture, this is an elderly patient, about 13 or 14 years old, that has severe calcium in the cornea. The calcium was sloughed out of the cornea, which left a Descemetocele in place. With this second picture, this is a very large Descemetocele seen in a dog with severe dry eye. Included in this picture is a hypopyon, which is the white substance in the anterior chamber as a result of the ulceration. A Descemetocele has an extreme risk of corneal rupture and is considered a surgical emergency. Surgical grafting is recommended and required in order to repair these eyes. Descemetoceles can be medically managed, however the client should be warned that they frequently fail and results in a corneal rupture, which may then require an eye removal. For a descemetocele, surgery is required for a successful outcome. Surgical options include a conjunctival pedicle graft, A-cell grafting, or corneal conjunctival transpositions. So here's a quick little video of a corneal conjunctival transposition surgery.
So we're going to create our keratotomy here with the 64 beaver blade. And we're going to remove this diseased surface of the cornea, this diseased epithelium, down into fresh corneal stroma. So we're going to remove this section here. Now we're going to create our graft, our CCT, by dissecting this about 50% of the way through the cornea, freeing this up there. We'll make our incision into our conjunctiva in order to allow us to then cut the limbus to free this entire graft up and have some movement out of the graft so that we can lay this into our ulcer bed there. So we're going to use A-dot Vicryl and attach 2 sutures at each corner for some cardinal sutures there, and that will allow this graft to hold in place while we go back and suture the entire graft onto the cornea. So again, A-dot suture, we're going to start here at the limbus, go through the conjunctiva and into the cornea. We're going to tie that down. This is going to be a simple continuous pattern all the way around this graft. This suture will stay in the cornea for about 6 to 8 weeks while it dissolves on its own. We're going to come all the way around this graft here, suture it down. Now that we've got this all sutured down, we're going to tie it down, remove our tags. Now we're going to perform a temporary tarsorrhaphy, closing off about 40 to 50% of this.
Next, let's talk about melting corneal ulcers. Melting corneal ulcers are a progressive stromal dissolution or keratomalacia. These are the most complicated and dangerous ulcers that we see in clinical practice. Normally, proteases and collagenases are produced by corneal epithelial cells, fibroblasts, polymorphonuclear leukocytes, and microorganisms. And all of these help to remove devitalized cells and debris from the cornea. In some ulcers, these proteases and collagenases contribute to enzymatic activity of the cornea, also known as melting. These ulcers typically start with a bacterial component. Treatment is aimed at stopping enzymatic breakdown and eliminating bacterial infiltrate. Corneal rupture is imminent if proteolytic activity is not stopped. So some anti-proteolytic agents include tetracyclines, topically would be terramycin, orally would be doxycycline, N-acetylcysteine, EDTA, as well as serum. So let's go over a quick case that I really enjoyed treating. This is Emily. Emily is a 10-year-old Papillon with acute onset squinting and ocular discharge. Her Schirmer tear tests were 15 millimeters per minute in both eyes, and she presented with this melting corneal ulcer, where more than 85% of her cornea was melting. She had a large geographic corneal ulcer and keratomalacia, as well as corneal infiltrate. So with Emily, we were unable to graft the cornea, as this would end up blinding her permanently. And as well, there was minimal normal cornea to suture a graft to. So we decided to treat Emily very aggressively. We started with ofloxacin every 4 hours, tobramycin every 4 hours, and triple antibiotic every 4 hours. We utilized terramycin every 4 hours, tacrolimus every 12 hours, carprofen every 12 hours, and doxycycline every 12 hours, and we had her wear an e-collar. We rechecked Emily 2 days later, and here's what the cornea looked like at that time. It's consolidating. There's a little bit more normal cornea around the edges. It remains very malacic at this exam, but it hasn't ruptured. I warned the owners at this time that it doesn't look good and it still may rupture. However, the melting is consolidating ventrally. The owners wanted to continue to proceed. We rechecked her 3 days later, and the peripheral cornea remains firm, and she's got good vascularization, and she still has not ruptured, and she's receiving all of her medications as directed. We rechecked Emily about a week later. She's dramatically improved, she has adequate corneal vascularization, and she's consolidated her cornea. She continues to be visual at this time, although it does have quite a large blind spot. At this time, she actually would be a good candidate for surgery for a corneal graft. However, the owners were happy with her progress and did not want to pursue surgery at this time. They're happy that she's gotten this far and they just wanted to continue with medical therapy. 2 weeks later, we see Emily. Her corneal ulcer has healed. She has a small amount of remaining inactive corneal vascularization. She's very comfortable at this point and she's visual. Four months later, I see Emily for a routine dry eye recheck. She has a geographic corneal scar, faint pigmentation. She's visual, she's comfortable, and the owners are extremely happy. Moving on to corneal ruptures. Corneal ruptures are a full thickness corneal penetration. They frequently involve iris prolapse, a fibrin plug, hyphema, as well as aqueous leakage. When evaluating these patients, there are some important considerations. Does the patient have a menace response? Does the patient have a dazzle response? Does the patient have a consensual pupillary light reflex? If the patient does not have a consensual pupillary light reflex or a dazzle response, vision is not likely salvageable through grafting techniques. Surgical options include corneo-conjunctival transposition, A-cell grafting, conjunctival pedicle grafts, corneal transplantation, and enucleation. These are all photos of corneal ruptures. These also come in various sizes, shapes, and colors. It's important to look at these and evaluate if they are truly ulcerated or not. Many times we see cases where they are ruptured and they've been misdiagnosed as melting ulcers or vice versa. One practice tip that you can utilize in your practice is if you see black flecks within that soft material of the ulcer, that is typically uveal material or iris material, and that means that it's a full thickness corneal rupture. Here's a series of photos of conjunctival pedicle grafts in order to heal corneal ruptures or deep corneal ulceration. Benefits of conjunctival pedicle grafts include it utilizes the patient's own tissue. There's minimal inflammatory response since we are using the patient's own tissue. It adds strength to the cornea and it adds active vascularization. Some negatives of conjunctival pedicle grafting is that it adds a blind spot. There's a large corneal scar, and magnification and surgical expertise are necessary in order to carry out a proper surgery. These are various photos of corneal conjunctival transpositions performed on canine patients. Positives of corneal conjunctival transposition include that it utilizes the patient's own tissue. There's minimal inflammatory response, although there's larger inflammatory response than compared to a conjunctival pedicle graft. It adds strength to the cornea. It adds active vascularization, and there's a clear visual axis post-op. Some negatives of corneal conjunctival transposition includes that it adds a blind spot. There's a large corneal scar, not as large as a conjunctival graft, and magnification and surgical expertise are necessary, and they are more complicated than performing a conjunctival pedicle graft. This is a case series of photographs of a patient that healed through A-cell or biocyst grafting. It was the full thickness corneal rupture, which a graft was placed on and completely healed, and the patient remained visual. Positives of A-cell corneal grafting include minimal corneal scarring, adds strength to the cornea, and they're more comfortable post-operatively. Negatives include that magnification and surgical expertise are necessary, they're easier to re-rupture, and they're extremely inflammatory post-operatively. In this study by Chow et al., 82 eyes were in this study that were evaluated of post-operative outcomes after A-cell grafting in dogs and cats, with 68 eyes having sufficient follow-up. There was minimal scarring in 47 eyes, moderate scarring in 12 eyes, and severe scarring in 9 eyes. There was a graft dehiscence in 19 eyes. Corneal lacerations are frequently seen in dogs, especially dogs less than 2 years old who have just met a cat for the first time. There is acute pain and you may see iris protruding through the cornea. The laceration may involve the lens capsule, and this leads to a cataract, lens-induced uveitis, and potential glaucoma. At this point, if the lens capsule is compromised, phacoemulsification may be necessary. So here's a series of photographs of a dog that was struck in the eye by a cat claw with a full thickness corneal laceration and iris prolapse. The iris was replaced back into the eye. The eye was filled with viscoelastic, and then the corneal laceration was sutured closed. There's a potential for post-operative intraocular bacterial contamination, persistent uveitis, glaucoma, and a retinal detachment. So it's important to tell your clients that there could be an issue of inflammation within the eye, even 4 months down the road after the initial insult. So in summary, knowledge of proper corneal anatomy will further help you determine the location, depth, and sometimes the cause of corneal disease. Determining an etiology will allow you to better direct treatment, discuss outcomes, and overall improve client satisfaction. Ophthalmic examinations should consist more of just shining a light into the patient's eye. Your antibiotic arsenal should consist of much more than just triple antibiotic, and knowing the depth of the corneal ulcer can determine if medical management or surgical management is necessary and whether or not you need to refer the case. Many surgical options are necessary, which can help preserve vision and avoid enucleation. This concludes the second module of corneal disease. Thank you so much for watching and joining.